Thank you very much, Professor Sohail Rafi, Head of Department, Ziauddin University Hospital. And thank you to my experts, along with me, Professor Rana, Dilawez, Nadeem from the King Edward Medical University, Lahore, and Professor Akhter Beg from the Shahid Bhutto University, Layari, Karachi. And today, my presentation is in the series which we have started from Ziad. Initially, we completed cerebral palsy, five lectures on the DDH, and in between certain videos we have discussed. And today, my topic is the Legg Calve Perthes disease, and I will take only up to the diagnosis aspect and differential diagnosis and present few cases. And the next lecture will be on the management of the DDH. As you see here, these are my expert, Professor Rana Dilawez Nadeem, Akhter Beg, and Imtiaz Hashmi, our head of department at Ziauddin Universities. And my lecture today will be based on the five aspects. I will discuss with the pathophysiology of Legg Calve Perthes disease, how to diagnose, how to classify, because there is diversity of classification systems available, and none of the one system is okay for the diagnosis. And then I will discuss about the life cycle of Perthes, how do it behaves in the long term, and then few case discussions. And the next lecture after 15 days on 6th March will be, inshallah, management aspects along with the video demonstration of the surgeries. So Legg Calve Perthes was initially reported by the George Kelman Perthes in 1910, and in the same decade, same years, the calve from the France and the leg from the USA also reported regarding this disease, which is a self-limiting disease. It means it ends with on and with some problems if there is a continuous wet bearing, and this commonly involve the femoral epiphysis, produce the necrosis of the femoral epiphysis, and goes through certain stages of resorption, regeneration, remodeling, and remodeling with or without flattening or the deformity of femoral head. And the ultimate deformity usually depends on the very variables at the time of presentation and the sphericity as per the progress of the disease and the weight bearing and the muscle forces. How do they produce a deformity? I will also discuss the pathogenesis, how the deformity is produced. So commonly, as per incidences, it is 0.2 to 19% in 1 lakh children, and sometimes it is a 1 to 1,000, and it is commonly in the white races, but it is not uncommon in the South Asian public. And its common period is between the 2 to 12 years, but highest incidences occur 5 to 6 years. And this will be explained in the next few slides why it is common in this age group. And also in the males. Females are less commonly affected. When they are less commonly affected, they have a bad prognosis, and we will also discuss why they have the bad prognosis. And it is 15% maximum bilateral, and most of the time the precipitation by trauma in 20% of the cases produce the avascular necrosis. Again, children tend to have a short stature. Mostly they are affected short stature children, and they produce a delayed bone maturation. And commonly it is due to the disruption of vascular supply, which has not been clearly diagnosed why this vascular supply, and multiple theories are available for this. But the children who are exposed to tobacco, even if they are not smoking, but their parents are smoking, or in the vehicles they are sitting there is smokers, their children also have the high incidence of the LCP. And coagulation abnormalities, children who have coagulation abnormalities may get more chance of the DVT. So it is said that 75% of the Perthes affected children have some form of coagulopathy, and 50% of thrombophilia patients also reports the Perthes disease. 89% of these children develop a delayed bone age, while 50% of these children who have a Perthes develop osteoarthritis in the late stages. And here is the theories, how do this Perthes develop in the femoral epiphysis, caput femoris. And if you know very well, there are 3 blood supply for the caput femoris. One is the metaphyseal vessel. These are the metaphyseal vessel which supplies around 50%, and most of the physis, the growth plate, gets blood supply from these metaphyseal arteries. And then there is a retinacular blood vessels. These retinacular blood vessels supply the epiphysis, and 25% to 15% to 25% supply is from the foveolar artery. So means the foveolar artery and the retinacular vessels, and these provide the blood supply to the physis, are secondary focus of the nucleus of the epiphysis, which later develops a femoral head. And the growth place is mostly supplied by the retinacular vessels. And all these blood vessels are the end arteries. They don't have the communication to each other, but they are end arteries, and they supply where they ends. They ends with, and then there are sinusoidal vessel, but each artery do not get anosmosis with each other. But all these supplies have the anosmosis extra bone, outside the bone. They anosmose here, but not intraosseous. So this tutor has explained in this way that up to the age of 3 years from birth, there are 3 blood vessels. One is foveolar artery, 15 to 25% supply. Then retinacular and metaphyseal arteries, they supply the 85% to 75% of blood supply to the physis and the epiphysis. But at the age of 3 to 5 years, in this age group, there is only retinacular vessels, and the remaining vessels obliterate, and then these vessels redeveloped during the after 5 years, and there is at the 8th year it is fully established. There is a foveolar artery which get established at the 8 years, and at the 13 years they have the full blood supply which communicate from the metaphysis to the epiphyseal area. Up to the 3 years, there are 3 blood supplies. There is foveolar, retinacular, and metaphyseal. Then there is obliteration, and around the 3 to 5 years or 3 to 4 years, only blood supply is the retinacular blood supply. But then it got re-established, the foveolar artery, which restart at the age of 8 years. Okay. At the 8 years, and after 13 years, again there is the 3 blood supplies, and they have an extra osmosis. But intraosseous blood supply from the metaphyseal to physeal area goes and redevelop at the age of 13 years. So this was the theory of the Trita, and they said the extra articular anosmosis, there is a circle of villus in between around the neck, and the cruciate anosmosis at the trochanteric area, but there is no intraosseous anosmosis. Again, they said each artery is in an island artery ends, and then it supplies a specific period of the blood supply. Like this artery goes here, it supplies only this portion, this artery supplies only this portion, only partly. Each artery is an end artery. So if there is obliteration in a small portion, this will do the every end of the part. It may be around this 25%, 50%, and 75% as we go in classification. This will make you understand that each end artery, if obliterated, it produces, if multiple end arteries are obliterated, then there is a more area of the avascular necrosis. Then there is a Catterall theory, and it is said mostly it is a traumatic preposition, and this trauma occurs because of the superior age of the ovulum, which obliterate the blood vessels and produce indentation in the head, and it will produce a deformity. Again, some people say there is an intraosseous increased venous pressure, which may lead to the problem of the AVN, avascular necrosis, and hormonal theory is also there. So how do these patients behave depends on the stage of the disease. In the very early stage, just patient complains of the fatigability in the daytime and the night rise crisis. In the midnight, they say there is a crisis, they have a poor sleep, and the evening rise of fatigue is another symptom in early stage when there is only synovitis. But as the disease progresses, they develop more symptoms like groin pain and thigh pain, which is referred to the anterior patellar area. And then there is a Trendelenburg sign. If they develop bilateral, then they produce a Trendelenburg gait. And at this stage, they produce a limitation of the abduction and internal rotation. And when the disease progresses more to the deformity stage, they have an increasing pain and limitation of movement. In this, their limitation of movement may be in any direction. In early stage, it's in the abduction and internal rotation. But when there is a deformity, then there may be a limitation of the rotations in abduction, external rotation, even in the flexion. They may not have flexion of the hip joint more than 50 degree. And then if there is a collapse, then there is a limb length discrepancy over there. So how to diagnose this? We have multiple diagnostic tools. In early stage, it present like as a transient synovitis, which we call it an irritable hip. And this irritable hip can be a reactive arthritis. It can be a viral arthritis because of the viral infection. It produces synovitis and transient synovitis, which is self-limiting. Sometimes very early osteoarthritis, early septic arthritis, and in the proximal femur metaphyseal osteomyelitis, at very early stages may lead to a synovitis, which we call an irritable hip. So this is the differential diagnosis. Along sometimes also the children with appendicitis also depicts the signs of the painful hip, and then we call it as transient synovitis. It means that early stage differential diagnosis contain these 5 areas. But the disease, when it is established with avascular necrosis, it may simulate like slip capital femoral epiphysis, and UK people say it is SUFI stage 1, early stage. And sometime following a trauma, minimum displacement or no displacement, but epiphyseal injury because of the trauma. They produce a differential diagnosis. We have to diagnose this disease at very early stage, and in some cases, the hypothyroidism, steroid induced in children, particularly with the nephritis, they take the steroids and it may produce a symptoms like a transient synovitis, and early epiphyseal dysplasia may also produce a symptom of the transient synovitis, which may mimics as the avian. And the tools which we have available are very varied and very multiple. In early stage, when disease is less than 2 weeks or 4 weeks, the technetium 99 scan and MRI are the best tools to diagnose. And the technetium usually indicates when more than 50%, then stage 1 and stage 2. But when there is stage 4 and 5, there is a less vascularity, more than 50% less vascularity it shows. And in the late stages, it shows a complete obliteration and complete less uptake. The MRI also gives a best results in the early stage. But when disease is progressed more than 3 to 4 weeks or 2 weeks, then it appears on the X-ray, and in X-ray with the special positions. And sometimes we do the tomogram, but more commonly we do the CT tomogram. And some people do ultrasound, which helps you to show the regarding the fluid inside or hypertrophy of the synovium inside. And arthrograms people also do for the early stage diagnosis. But when disease is established and for research purpose, people do 3D CT scan, arthroscopy, angiography, venography, intraosseous hydrostatic pressure measurement. So these are the tools which we use it, and I will show you in detail in the last few slides how they appear and how they show the diagnosis of the Perthes. Now the lifestyle of the Perthes, how do it appears and how do it ends. Basically, we say it is the secondary to vascular occlusion, but it is idiopathic. How do it gets the avascular occlusion? It is not known. Multiple theories we have discussed, but it is a self-limiting disease. And this disease take 4 years, and in some children 2 years to 4 years time, when it significantly ends it, and it produces ultimately full recovery. So it is said the revascularization is the rule in the Perthes because it is a self-limiting disease. So this revascularization may occur by reossification with the creeping substitution, removal of the dead bone by the creeping of the new vascularization tissue and the osteogenesis. So it is rule it will revascularize. So during this revascularization, it produces multiple changes in the bone. And these changes are metaphyseal changes. It may produce a metaphyseal abnormality. It may produce a physeal abnormalities. It may produce an epiphyseal abnormalities or the deformation of the femoral head. And this all depends on how the child behaves, how much pressure he is exerted on the metaphyseal or that hip joint, and ultimate will be the normal or little bit deformed bone, and this will be discussed. So here is the deformity, which may range from the collapse. It may be a flattening it may produce a saddle deformation or bilobed femoral heads. It may produce a metaphyseal broadening. It ends with the cosa magna or cosa plana. And all this depends on the pressure in the hip joint, weight bearing, and the progress of the disease. And now we will explain how do this deformity occurs. So here is the blood supply again, a blood vessel, extra osseous blood supply, cruciate in osmosis. Then here is the metaphyseal arteries, and then the epiphyseal arteries. The epiphyseal arteries, metaphyseal arteries, and the foveal artery after age of 3 years, if there is an occlusion here, it initially produces a problem in the area of the growth plate or the supply in the secondary center, primary center of the epiphysis. It may get necrosis. When it gets necrosis, it gets softened and gradually replacement from the peripheries, from lateral pillars. So I said one from this side and this side, because blood supply is there, they get revascularized and they produce a revascular new bone formation with new vascularization and replace this dash bone gradually from periphery to the center. So this time takes around 2 years to regenerate, and this is the area of the deformation. How do the hip under pressure behaves, and what are the pressure points? If the acetabular neck is pressing here, it will produce a bilobe. So because of the pressure, this area height of this is reduced, and the physeal depth and the circumference also get reduced. And further deformity depends on the pressure areas which is produced. Here again, it shows how there is a disruption of the retinacular vessels from here, and the metaphyseal vessel. If they are disrupted, then the growth plate will also be affected, but mostly it is the epiphyseal vessels which supply the epiphysis get disrupted. So there is a necrosis here. Once there is a necrosis, there is a regeneration as well, but there is a softness of bone in the center. And when this central bone collapses, the cartilage remains high. When the cartilage remains high and the osseous bone gets collapse, then it produces a crescent sign, which is commonly you see in the Perthes, the crescent. It is because of the dense bone which gets collapsed and the cartilage remains there, but it regenerates. And this regeneration depends on the pressure areas. If the pressure of the epiphysis or the acetabulum is here, it produces a bilobed area and the wide, broader physis. But in the epiphysis, growth place is disrupted, growth place regeneration, and metaphyseal necrosis because of the cyst formation. When they regenerate, it produces a metaphyseal deformity. So this is the microscopic evidences of the epiphyseal necrosis. How do they occur? In the stage 1 and then the stage 3, then the 50% more of the 50% bone is involved. It produces a necrosis and the flattening. This also shows the flattening. So microscopic evidences. This slide very nicely shows when the bone is soft because of the avascularity and regeneration, revascularization, and there is a pressure area. So this is the avascular segment, which is mostly anteriorly and the superiorly anterior. And here is the cartilage. And here is the synovium. This synovial hypertrophy and the cartilage hypertrophy causes the extrusion of the femoral head. And when the height decreases, definitely it becomes broader. When it becomes broader, there is the physis, epiphysis at the tip of the cartilage of the acetabulum. Here it produces a pressure area. If they not produce a pressure area, this cartilage hypertrophy here and the synovial hypertrophy here and the fluid, they cause the extrusion of the femoral head from the physeal area, which we measure with usually with the CE angle, but here we measure with the percentage of the femoral head. As you see here, more than 20%, there is an extrusion of the femoral head from the edge of the acetabulum. But when this extrude outside, the bone is soft, then it produces a pressure area. This is the edge of the acetabulum, which produces a pressure area here, and it causes the deformation. And if deformation occurs here, in the long term, is produce a deformed bone, deformed femoral head, and then there is early regeneration. This is not only because of the weight bearing, but the muscle forces acting on the flexion and extension, over 360 kilopascal pressure on the femoral head. and the edge of acetabulum produces a dimple here, and this dimple causes the bilobed head or with saddle type of femoral, जो घोड़े के ऊपर एक saddle रखते हैं, उस तरह से एक ये depression create होती है, and it produces a deformation of femoral head. So this was the pathogenesis of the deformity. How do it occur? Because of the softness, the new vascularization, revascularization, bone is soft, there is hypertrophy of the cartilage and hypertrophy of synovium. This causes extrusion of the femoral head from the acetabulum. This extrusion further get deformity of the bone because of the pressure of the edge of the acetabulum, and in this way to produce. Now, what are the prognostic factors which causes the deleterious effect on the femoral head and the deformities and the problems in the long term? So it is said when age is more than 8 years, the prognosis is not good. As the age increases from 6 years, less than 6 years to the 8 years, the prognosis is less. So it means it is the inversely, prognosis is inversely proportional to the increasing age. Similarly, female if appear in the female and the late stage, the prognosis is worse than the male. And when the male have the less good prognosis as compared to the female. And then there is certain radiographic sign. If these radiographic sign we call head at risk sign. If they are there, then the prognosis is not good. So here I can show radiologically, will detail discuss what are these the head on risk sign, because our students when appear in exam, they cannot explain these findings. Therefore, I will discuss mostly on the concentrate also on the how do these signs appears. So this radiographic signs may be Catterall is defined as 6 signs. One is age, and 5 is the radiological sign. And along with that, some people have had metaphyseal changes, metaphyseal broadening, and that is also included in the Catterall sign. And the extent of the epiphyseal extrusion, as we have explained here, how much this extrusion is outside. The extrusion 25%, so peripheral area will be bilobed. If extrusion is 50%, then here will be the bilobed area. I will show you in the later slide how do this produce. So now the detail of the changes which occur in the, and they are the prognostic factors, important prognostic factors. So here is the metaphyseal cyst formation. This is physis, which is dense, little bit flat. There is increasing area from the teardrop to the edge of the acetabulum. But if you see carefully, here, yes. If there is there is multiple cyst formation in the metaphysis. In early stages, there is cyst formation in the physis. That is not so it's a bad sign, but metaphyseal cyst formation here you can see 3 cysts, this cyst, and this cyst. When they combine and collapse, they produce a shorter neck, and when they heal, they produce a broader physis. So metaphyseal widening occur because of this collapse here, because of cyst collapse. Then they regenerate and they produce a mega here, a mega metaphysis, which usually we treat with the chelectomy. And then the regional osteoporosis, that is called simple osteoporosis here, but this is less important as compared to the metaphyseal cyst. If there is a metaphyseal cyst like this, then there is a significant importance and it is a bad prognostic sign. Then physeal growth plate signs. Growth plate, if the growth plate avascularity occur, there is a premature growth arrest because the cells are damaged and the deformity is per the premature fusion of the physis occur. And how do this deformity occurs? It may produce a varus deformity, cosa vera. It may produce a cosa valga. It may produce a shortened femoral neck. I can explain here this. If the physis portion, this portion of the physis is involved, so it will not grow. This will not grow, this portion will grow, therefore there will be cosa vera. But if this portion of the physis is involved and it is not growing, this portion will grow more. So it will produce a cosa valga. But like this whole of the physis, when it is involved, then there is the short neck deformity. So metaphyseal changes produce cosa vera, cosa valga, and shortened femoral neck. And if it produce a cosa vera, then it produce a trochanteric overgrowth because of the lever arm. Lever arm effect will be shorter because neck is short, the lever arm is. Then the traction apophysis is here at the metaphysis, this trochanteric area. So it will produce a beaking. That is called beaking of the greater trochanter with coxa vara. So this is again a finding because of the prephyseal change in growth plate changes. And when there is a growth plate changes, it produces overgrowth of trochanter, varus, valgus. Definitely there is a changes in the biomechanics of the hip, and they produce a Trendelenburg limb. And if it is bilateral, they produce a Trendelenburg gait. So when epiphyseal change occur, it may restore to the normal. Epiphysis means of the caput femoris, when there is restored normal, because it is a good regeneration and good early stage disease, and there was no extrusion, so it produces a good regeneration. But when the part of the later stage disease, it may produce a flattening, it may produce a coxa magna because of the broader, as we have seen here in the early stage slides here. There is a coxa magna. This will end with the coxa magna as compared to this normal head. This is a broader head. So it is called coxa magna. Coxa magna will be another changes because of the epiphyseal changes, epiphyseal above the physis. It may produce a deformation. As already we have discussed, deformation, it may produce a bilobed saddle type of femoral head. So it all depends on the pressure areas and the extrusion, how much percentage of the head is extruded from the acetabulum. So now, little bit about the Catterall sign. Most of the students sometimes ask me, where is the Gag sign? What is the Gag sign? We can't understand. So I will now explain the different signs as per radiological evidences. Here, if you find there is a flattening on the medial side. So this physis, along with a necrosis at the lateral edge, anterior edge here, it produces a V type of necrosis. That is an epiphyseal-metaphyseal necrosis. Then this V is called the Gag sign. And this was the Professor Gag who has explained. Then calcification lateral physis. This is the regeneration area. After extrusion, there is a regeneration here. And this regeneration has produced a calcification at the metaphyseal epiphyseal area. This is again a bad sign for the prognosis because it produces epiphyseal fusion, premature epiphyseal fusion here. That's why there is a calcification, and it has produced lateral calcification at the epiphyseal metaphyseal area. Then lateral subluxation. Already we have explained this much subluxation is extrusion because of the cartilage hypertrophy here and the synovial hypertrophy here and the flattening. So it is a lateral, then there is horizontal. As the age grows, and there may be, instead of the obliquity of the physis, this may become a horizontal femoral physis and metaphyseal cyst formation we have learned. So there are the 5 Gag sign: lateral calcification, lateral subluxation, horizontal proximal femur, and the metaphyseal cyst formation. This was added by someone else, but Catterall has shown 1, 2, 3, and 5. And the 6th was the age of the child and the female. So we will explain again when we look at the Catterall sign. Once we have diagnosed this is the Perthes, then we need a classification. And classification basically we do to know the prognosis of the disease at a disease stage when they reach you. And most popular classifications are the Waldonstorm classification, which define the stages of diseases. Then the extent of physis involvement. In here is the Catterall's classification 1971 is most popular. And then the Salter and Thompson 80s. In the 80s it was introduced. And another is the extent of epiphyseal collapse, height of the epiphysis. When it collapses, that produce that has been again a classified lateral pillar classification, Stulberg classification. Stulberg classification mostly shows the sphericity of the femoral head, and we will explain in little detail later. So Waldron stage 1 is the initial stage when there is an increased radio density because of avascularity. The calcium is not being drained outside, but more calcium is deposited with the osteogenesis. So it produces increased radio density, and stage 1, then ossific nucleus will be smaller. There is increased radio density of the ossific nucleus in the epiphysis and medial side widening. So it will be stage 1A. As age increases, then you will find a subchondral fracture. Stage A, there is no subchondral fracture. It's a very early stage when you say there is a transient synovitis stage, but no significant radiological signing. But then there is a fractures, and these fractures occur because of the epiphyseal and metaphyseal collapse. The epiphyseal cyst appears and they collapse, they produce a fracture, and here you can find a crescent sign. And then the metaphyseal cyst formation, they may collapse and it produces a shorter neck, a broadening neck. And when there is a collapse, there may be flattening of the ossific nucleus and further regeneration. So here is the initial stage. You can see here hypertrophy of the capsule, and there is little extrusion, but there is no significant changes in epiphysis, physis, and the metaphysis, but there is a density. So it is early stage disease which shows the density. Here it can be classified. You can find here there is a cyst formation here. There is a cyst formation here, but there is no changes in the physis, no changes in the metaphysis. So ossific nucleus is smaller and increased radio density because there is no calcium drainage because of avascularity. And when it is dense, the size is smaller, so you can find the increased joint space here. And then the widening of the medial joint because of the hypertrophy and the cartilage. This all repetition is to get the students bombardment. These are the findings and they can retain it. Therefore, I repeat every time the findings. There is a necrosis here, there is a widening of space, there is a smaller nucleus, and the flattening, no flattening at present. But when you go stage 2, 1B, there is a subchondral fracture of the epiphysis. So when there is subchondral fracture, there is a collapse. When there is a collapse, there is a flattening. So here is the flattening area, but crescent sign you cannot see because the crescent sign usually appear in the stage 2. But there is a mild flattening of the surface here and little extrusion, which is not more than 10%. And when you disease progress, this pressure overhead may produce, but there is no changes in the physis, there is no changes in the metaphysis. So this is stage 1B. When you go stage 2, that is advanced stage, which we call it a resorptive area. When there is a resorption of bone, density disappear, but there is a fragmentation. So physis appears, epiphysis appear fragmented. Radial density is there, but epiphysis and the ossific nucleus get fragmented in the pieces because of the end artery supply. Then when there is a collapse, there is a flattening. And there is a flattening, there is a broadening. When there is a broadening, it produces lateralization of the femoral head because we already explained that there is a medial side broadening. And on the stage 2B, there is a sequestrum formation. The cyst, which is there, they will combine and they produce a sequestrum. And from lateral and medial plate head versus whole head flattening, it may produce a lateral or medial flattening, or the whole of the head get flattening. Somehow minimal fragmentation and flattening. Some in few children also there is a minimal changes. So here stage 2 is a resorption stage of fragmentation. So you find in the early stage there was no fragmentation significantly, as you said. There is only single cyst formation which later develops. But if you see here, there is multiple cysts in the epiphysis, and this was the ossific nucleus, which has already been damaged. So there is a cyst here, there is a cyst here, there is a cyst here. Very few changes in the metaphyseal or physeal area. And there is a flattening. Then there is a medial joint space here. So this is called stage of resorption. Now healing is continued after 6 months of the disease. And this takes 2 years to regenerate further. And here it shows one of the cysts here. This is radiolucency. Fragmented epiphysis. There is one fragment here, other fragment, and you can find one fragment here of the physis, another epiphysis, another fragment of epiphysis. This is radiolucency, necrotic. This is radiodensity of the nucleus. But here is little changes in the growth plate as well. But there is no metaphyseal changes. So as the flattening occurs, there is a lateralization. Lateralization produced because of the extrusion of the cartilage. So it is stage 2. And in the diagrammatic way, it shows the multiple fragmentation here in the lateral and more severe type, same child, more severe type of the changes. And at this stage, it was reverse derotation was done and head was contained so that it do not produce, when it regenerates, it do not produce a saddle type of femoral head. So this is the intervention by the treatment we call. So here the sequestrum formation, this is the sequestra, ossific nucleus sequestra, and medial and lateral pillar head involvement, whole head may be involved, some people a little less than that deformity. Then stage 3. Stage 3 is now regeneration after 2 years, after 2.5 years as the disease starts. Then this also takes 6 months to 1 year or 2 years to re-ossify. And whatever the deformity was there, it will reform in that shape. But if you contain the femoral head within the acetabulum, this re-ossification gives the good results. So here is the appearance of new bone, medial and lateral, because it starts from lateral and medial areas, which already discussed. The arteries come from lateral side or the medial side, not from the center where the growth plate is there. Then central and anterior portion that ossify lastly. Central portion will be lastly because of the creeping substitution from the sides. And then once there is a disappearance of the radio density, it is regenerated fully, and somehow improvement in the shape, while other worsening of the shape of the caput femoris depends on the pressure areas on the femoral head. So here stage 3, new bone formation stage. So there is you cannot find the necrosis here, but the regeneration has started. Femoral head is good content. So we expect that this head will regenerate with the good, without significant deformity if it is contained well. So here is again necrosis area which is being reabsorbed from this re-ossification from lateral side, the medial side, but as there is a growth plate, it do not cross from the center. Therefore, from periphery, it goes as with the creeping substitution, and with this creeping substitution, whole of the femoral head is reformed. And it is said the last portion reformed will be the central because the ossification starts from the periphery. So here is the stage 3B, when all the radio densities disappear and there is a good regeneration, and this head is little height of this head is less, so there is a mega head, and there was a metaphyseal changes. So metaphyseal is also broadened here, but neck is not short because there was no epiphyseal arrest here. So somehow improvement may be less worsening as compared to. So then stage 4 is called, this is a now completed 3 to 4 years. After 3 to 4 years of this life cycle, there is a remodeling. Whatever remodeling occurs depending on the Wolff law, where there is more stress, more bone formation. When less stress, less bone formation. That is called Wolff area, Wolff law. And this Wolff law is in the stage 4. Then the normal radio density of the epiphysis, caput femoris reappear. Shape of femoral head is remodeled till skeletal maturity. The children is growing from 3 years, 4 years, now 4 years, and 7 years, and 7 years further with the remodeling continued to skeletal maturity. So when there is a skeletal maturity, healed stage, what was left? It was flattening, it was estruan. So head is reformed, shape is reformed, and it also produces reformation shape of the acetabulum. This was the case if this case was initially operated with the shelf or the containment of the humeral head, then this head would have been inside and produced as a normal head. But this all depends on the pathology as they progress. So this is the detail of the Waldonstorm. Stage 1 is initial stage of the synovitis, irritable hip we call. Then there is fragmentation, then when there's significant limitation of movement, then area of re-ossification, he is regaining his femoral head, and the healing stage. And this is the time period which is written. Initial stage remains for 6 months. And after 6 months, 2 to 3 years, there's a fragmentation stage. Disease continue to progress up to the 2 years additional. It means 3 years, up to 3 years from beginning. 3 years from the beginning, it produces a fragmentation stage. So 2 and 2.5 years is the area which is very important, and this needs a treatment of the containment. And once this is the dormant stage, this is called re-ossification area. This is again an important time duration period when you need to contain the femoral head and give the good femoral head coverage. And lastly is the remodeling, which continue healed stage. This is healed stage, and it continued up to the skeletal maturity. So we have this area from start of this from 6 months to 3 years, where you can intervene and prevent the deformation of the femoral head. And it initial stage just a symptomatic treatment, and calipers you can give. Calipers you can also give on this area. Now we switch over. This is again the details of the Waldonstorm stage in single slide. So there is a Catterall classification, which was initially in 1971, and then it was modified with additional areas of radiological finding in 1983. So this has an inter-observer reproducibility very poor, and but mostly when there is a demarcation of the avascularity and viable tissue, then it was a very important classification to be used. So it is grouped in the 4 groups: group 1, group 2, group 3, and group 4. And most of this grouping is done because of the area of the, if 1/4 of the area is involved, then it is type group 1. If more than 50% area or half of area is involved, then it is called group 2. But only 25% left and 75% area is involved, it is called group 3. And total head involved is called group 4. So it is depending on the area of the involvement, and with addition to the formation of the metaphyseal cyst, epiphyseal cyst, which were added in 1983. So if you see anterior epiphyseal 1/4 and no deformation, anterior less than half, central collapse. In the there is a central collapse, then it is the group 2. But when there is more than 3 parts is involved, group 3, and when we go to the next details here at 83 classification, it shows the same percentages of 25 to 50, more than 50 to 75, and 70%, but some additional findings were added in 1983. So here says it is 25% involved, early stage, there is no height is intact, but he said epiphysis, there is a sequestrum formation here. This is the sequestrum formation, epiphyseal cyst formation. Here also you can find a Legg sign in the we will discuss their Legg sign, and then there more than 50% to 75% area, only smaller portion is left. The smaller portion is left, whole of the head is necrotic, and head of the, you will find head in the head, which is said, एक head तो ये है, one head, and other head is sequestrum here. So sequestrum appears as a head in the head, and it also depends on the collapse of the femoral head. And there is a deformation as well. But when there is more than 75%, it means total head involvement. There may be a flattening, there will be a density, there will be deformation, and gross metaphyseal resorption changes. So treatment is the best in the early and second stage, and sometime in third stage it will give a good results. But the prognosis less with the treatment, even with the operative treatment, in the 3 and the 4 stage. So here is the detail of the Catterall classification. Less than 25% of head is involved, anterior portion. There is a no collapse. On radiography, you can see here, there is a no collapse, but less than 25% head is involved. And then the Catterall 2 classification, 50% and central portion of the head is involved here. In central portion, half of the head is involved. Here, sometimes you find a smaller metaphyseal cyst formation as well, and you can find a crescent sign as well. You can find a Legg sign as well in this. And this is the, again, central necrosis, and this is the density, which is later stage. So when there is a 3, more than 75% of head is involved, there is a physeal changes as well. In the 2, there was a metaphyseal changes. Here is a physeal changes. So this may go into the epiphyseal arrest, or premature physeal arrest here, and it will produce shorter neck deformity and the collapse of femoral head, which may be a larger. And then the stage 4, total head involvement, total necrosis, epiphyseal, metaphyseal cyst formation, and premature growth arrest it may produce. So these, most of the people you may not have seen, this is the collapse, more than 50% area. When the bone collapses, the cartilage remains back in the head. When the cartilage remains back in the head, it produces a sign, white area. On the X-ray, you will find a black area in the white. So this is the called crescent sign. Cartilage is there, and the collapse of the central portion, and it produces a crescent sign. And when there is a crescent sign, it is a bad prognostic sign. So here is another details of the Legg sign, calcification, and little bit explanation. So this Legg sign is a V particularly here, epiphyseal metaphyseal area on lateral side epiphyseal. Then the calcification, speckled calcification, the lateral subluxation, diffuse metaphyseal cyst formation, and horizontal physis. This was added in 1983 by someone else, but there's 1, 2, 3, 4, and 5, 6 signs usually ask head at risk by the Catterall, and the age, more age in the female gender. This has the bad prognostic signs. If you see details, how do the Gag sign appear? This is the Gag sign. Epiphyseal metaphyseal necrosis on the lateral side. And when there is lateral calcification, there is a lateral calcification here, and this is the extrusion. Extrusion are lateral subluxations in here. You should not forget the crescent sign and the Gag sign, which is very important sign, which can see lateral calcification again is a bad prognostic sign, and 3 is the extrusion of lateral femoral physis. So here is the chaddi mein jo ye nazar aa raha hai, this is the Gag sign, which is explained here, the Gag sign. Another Gag sign here. Here is the Gag sign, epilateral X-rays, and here there is no Gag sign, but there is a Gag sign here. So you can find the books as well. Again, the Catterall sign, the extrusion. The extrusion is the red area. Then metaphyseal reaction. The cysts were there, they collapsed and produced areas, and there is the cyst formation, which is yellow area, the metaphyseal changes. This is the physis. This is the epiphysis. This is again a white area, which shows the lateral reaction and Gag sign, typical signs. And here is the metaphyseal cyst formations. These are the bad prognostic sign as explained by the Catterall. So other classification is lateral pillar class. How much head portion is involved, how much collapse is there. The group 1 is no density changes, no loss of height, but lateral pillar height is maintained. We will explain in the figures as well. Group B is lucency in lateral pillar with loss of less than 50% of the height. In group C, more lucency in the lateral pillar, but loss of the height is more than 50%. And then the fourth is the borderline, combination of these. So A is the, here we can explain group A, lateral pillar is maintained with the full height, good outcome. Let group B is maintained lateral pillars 50% high, less than 50% height is the more than 50% is saved, and our diagnosis in the midline. But group C, more than lateral portion of the head is involved, height is more than 50% lost. So our prognosis is poor. It will produce a saddle type of head. It produce cosa magna. It may produce cosa vera. So here is the lateral pillars. 1, 2, 3 pillars. This is the lateral pillar. When is one of the lateral pillar is involved and height is not lost, this height is maintained, and it is less than 25%, this height is maintained. So it is type A, Herring's type A. This portion is lateral pillar is maintained. But here we find this lateral pillar is height is less as compared to this. There is no necrosis, no flattening here, but here lateral pillar is partly along with the central pillar, there is a collapse. So height of the lateral pillar is less. But if you see this, height of lateral pillar is involved more than, less than, in between, not more than 50%, less than 50%, height is little bit maintained. But here you find more than 50% lateral pillar is fine. So his head will develop like this. The flattening will be like this. So it has a bad prognosis. So lateral classification is simple classification depending on the portion of the lateral side which is involved and the collapse which is involved. Here is the more collapse here and the flattening, and the more collapse on lateral pillar, it produces more worsening like this. It will end like this. This will end like this. This will end like this. So lateral classification is there. So here is again, there is a no density, and this is the height is maintained, and total height is also maintained. And again, you find here, there is a collapse here, and there is a flattening, a lateral plus height less than 50% height of this. If you find is more than 50% in the C, more than 50% of this should be like this. But here, if this collapse is there, and there is a more loss of the height, more than 50%, it is C. So it is B, which is unclassifiable. It is not more than 50%, it's not more than less than 50%, but the flattening is there. Radiodensity is group B and C. It is a moderate type of the prognosis, but prognosis is worse in the C. Again, there is a lateral pillar is necrotic. You find here there is a fragmentation of the physis, and height of the physis is reduced. So it is called B or C group. Then this classification you cannot be applied in initial stages. Initial stages only you can start the Waldonstorm stage. But in 33% cases, you need to wait for this classification to appear the lateral pillar necrosis and loss of height. And then there is a Stulberg classification. Stulberg classification basically late stage when the sphericity, congruity is maintained, congruity 2 millimeter lasts, then it's a spherical, irregular femoral head is there. So here in two stages, when there is limited movement, range of motion, and stage 1 and 2 here it has passed, there is a synovitis, it has a good prognosis. And when there is a sphericity, when a head is not congruent, then there may be a coxa magna, it may be a short neck, it may be an abnormality of steep acetabulum. Then as the deformity increases, the grading increases. This is also used in another classification. So here it shows the normal type 1 Stulberg, type 2 less sphericity, more abnormality are the cosa magna. You will find there is a shorter neck, more cosa magna. Here is a total necrosis, which is called type 5. So this classification is basically all these three classifications. But you must remember the most common classification nowadays is the Waldonstorm and the Catterall. Waldonstorm is a more specific classification, more based on the treatment area. And this classification usually give you results how much prognosis will be later on when you have to intervene the disease. So there is imaging or multiple tools how to diagnose. MRI used in early stages. It gives you good configuration of acetabulum. It gives you good articular cartilage surface area definitions, and femoral caput contained a little bit S2 in early stage. It will give also information about the joint effusion if it is available and synovitis, and this shows the effusion and the synovitis in the early stage necrosis. And then there is a CT. CT 3D images are also used, but it is in the little bit less stages. When there is deformity, it will tell you about the acetabulum and the caput size and shape. But some people use ultrasonography in early stage when you find a joint effusion, assess the shape and cartilaginous caput. But some people use TC99 bone scan, and it has a less specificity as compared to the MRI. So mostly we use the MRI. Then some for the research purposes, and when there is a problem of the diagnosis, some people do the arthrography and to see the cartilage area, necrotic area, flattening, crescent sign, and what is the shape of it. Then they may debride as well the synovium, and they could give the good containment as well. So advantage is assessment and sometimes excision of the synovitis, synovial thick synovium removal, so that head is contained inside. So this ends the how we can diagnose the cases, and now it is for the student to reply these two case discussions. So this was the case. The 14-year age boy, and for the last 10 years he has a problem. Okay, he has a limp, he has pain in left hip joint, and clicking felt when he moves the left hip joint while walking. So what type of stage this can? These are the signs the patient present with the limp, pain in the left hip joint, and feeling of clicking. So he had a detailed history, and around 4 years at the age of 4, because he is 10 years now. At the age of 4 years, he had a history of trauma, but there was no fracture. He was managed conservatively. 1 year later, he developed pain in the hip joint and developed limping gait. So he presented the limping gait. It means this was an stage 2 Perthes disease. It is not the transient synovitis stage. What will be the prognosis in this age group? 10 years.
So the prognosis will be better in this case, that it's the Waldonstorm stage 1, and we may proceed with conservative management and watch and wait for the further progresses in signs symptoms in the clinical findings.
We will see in the X-rays. So it is age 10, male, so it has a moderate prognosis. It is not less than 6 years. It may not regenerate fully. He is a sports child. Okay, so pain off and on increases. It radiates to the leg, aggravate by walking, relief by analgesic. So what will be the diagnosis, differential diagnosis here when it is relieved by analgesic in the night cramps?
So the differentials might be infective causes and might be the reactive hip joint, and we may rule out the other traumatic causes in the case.
Here, night cries in relief with analgesics. The different diagnosis most will be osteoid because it is advanced stage. If there is infective stage, he cannot move his hip. Okay, so in this stage it will be.
जी sir.
So this is his finding. Let me know, is the trendling positive or negative? He stand on the right on this side, and he stand on the right side, and this is left side. Which side is affected? Is there any positive Trendelenburg or not?
Sir, the picture mentioned with antalgic gait seems likely to be a positive Trendelenburg gait sign with the on the right side.
On the right side, okay. So here is the full spinal movement, so he don't have a problem in his spine, but there is a little bit shortening on the left side. Okay, this is 1 centimeter shortening. What do you expect now in the physis? And there is a limited internal rotation, limited abduction, as you can see here. Okay, limited external rotation and limited abduction. And there is a 1 centimeter shortening. So his deformity is little bit stage 2.
So stage 2.
In the lateral pillar, it will be B. In the Catterall, it can be a C. And in the Waldonstorm, regenerative C, because 4 years he has passed. Okay.
Exactly, sir.
He has a good range of the abduction, external rotation, and flexion. He can squat as well. Okay. And Thomas test is positive 15 degree. So he has a flexion contracture on the left side. Okay. But on other side, there is also little bit flexion contracture.
Ji, sir.
Okay. So I have the X-rays which were a little bit late, 4 years when he came to us. I don't have an X-ray of initial stages. So what is the findings now? Lateral pillar में 50%, अब ये 50% saved है ना? And this is the more around 50%, and height if more than 50% down. And in the healing well downstream, which stage? Reossification stage, because density is getting back and there is a reossification. Is there an extrusion here? Little bit extrusion, but there is no gag sign. Okay. So again,
Ji, sir.
2004, there is a fragmentation and sclerosis. Flattening is more important. The fragmentation, sclerosis, but this is the regeneration stage. So in 2004 again, okay, there is a Waldonstorm disease stage cattle. Now we will move further. The stage 3 is the Waldonstorm, because this is reossification stage. This is reossification. Stage 4 Catterall, because of the significant high distance. But stage 3 I will call again. Not the total. This portion is less involved. So it means stage 3 Catterall. Hearing may more than 75% is, as she was saying, the C. So B and C, borderline. It is borderline. If up to here, then it is C. If there is a little bit portion, more than 25% is there. It means 75 and 50%. So stage B and C. And Stulberg, what you find Stulberg? Sphericity, but you cannot apply this Stulberg at present, because there is no full formed head, but there is a necrosis. So once it redevelops, there was one question, that if one side of hip is involved, should we treat the other side simultaneously? Yes, in Sufi, only in Sufi,
Only
slip
so. Yes.
chemotherapy, not in Perthes, because Perthes is not necessarily to occur bilateral. It may occur one side only. So we should not intervene other side unless a symptom develops. But we can do early management when he develops symptoms on that side, because already knowing that.